Welcome to CareTalk, America's home for incisive debate about healthcare business and policy. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the CEO of CareCentrix. David, I hope you have your A game on today because we've got a phenomenal guest, Dr. Jenny Schneider, the CEO of the newly launched Homeward, the former president of Livongo, athlete, mom, and thought partner, and a person who's really deeply personally committed to reforming healthcare, leveraging technology in the right way. Welcome, Jenny.
Thank you. Delighted to be here with you. Thanks so much for the time to chat.
Well, John, I'm speechless. I think I better be on my A+ game with that kind of interview. So while I sit here stunned, I'll let you ask the first question.
Jenny, how many 12-year-olds actually want to be an endocrinologist? Can you tell us a little bit about how you started to become a doctor? I mean, talk about someone who had a planning hat on early. That's really impressive.
Yeah, well, the answer is hopefully none moving forward when you hear my story. So the reason I wanted to become an endocrinologist when I was 12 is because when I was 12, I was diagnosed with type 1 diabetes. So that was kind of the entree into the healthcare profession, if you will. I would say that my own endocrinologist, a man who recently retired, Dr. Roger Nelson at the Mayo Clinic, who wrote recommendations for me throughout, college and postgraduate, was an incredible physician in that he gave me a tool set and a belief that I could handle anything and do anything. And the way in which I was treated through his eyes, we use the word empowerment. I really was in control, and he was there as a support system to help. And it really changed the way I thought about health and thought about care, made me pursue going to medical school myself. But it was an incredible experience. But the long and short of it is hopefully moving forward with a cure for type 1 diabetes, there'll be no 12-year-olds who want to be an endocrinologist.
Well, that sounds good. So did your commitment ever waver along the way, or was literally 12 and you said, that's it? I mean, how did your view about what you wanted to do change from 12 to, when you graduated medical school, I guess at age 17 or 18, based on the send up John just delivered at the start?
There's no Doogie Howser, MD. That's not in the cards here. I will say that when I went to medical school, I skipped the entire week where they make you sit in class and look at all the complications of diabetics who don't take care of themselves. I didn't go up to class. I didn't show up at class. I hated it. I am not an endocrinologist. I never went into endocrinology. But I actually think that juxtaposition of the person being at fault for their health, that's how you're taught in medical school. It's the diabetic, it's the thing that they didn't take care of themselves and this happened. And I would sit there and think, man, I am doing every single thing I can and I'm still can't get my numbers to be perfect. It's not a try harder kind of condition. There are things that happen in health and care that you can't do anything about. And so it was a pretty eye-opening for me.
I just think you made this point in other conversations we've had, Jenny, but that you are not your condition is really something that I think healthcare still doesn't get. I mean, we in the 90s, at one point we at Oxford, we were trying to convince people to call healthcare human care because we were so focused on the system that we forgot about the humans. And I just think that one of the things that's very powerful about the way you talk about diabetes, and it's true of anyone who actually wants to work with people who got a chronic condition, is to think about it from how to live your life as opposed to what's impeding it. And maybe you could talk a little bit about how that's animated the way you kind of show up at work at places like Livongo and Homeward.
For sure. I think that Livongo and Homeward similar in that we try to think about the care that we are offering to people by understanding the pain points to the person receiving that care. So rather than take I am the doctor and you must hit a blood pressure of X, Y, or Z, and here's the following medications that are recommended to you. Instead, you say, wow, this person has blood pressure that's elevated. What is it that's standing in their way from their point of view? Not from the healthcare delivery system, but from their point of view. What are the pain points? Well, turns out I'm an hourly wage earner and my doctor's 2.5 hours away. I'm not sure I would go to the doctor either, right? I can't get my prescriptions. I don't actually have a home where I get deliveries. I don't live in a safe neighborhood. What does that look like? And what does that mean? And so once you start to, we call it the pain map, right, of the individual. Once you start to map that out, the solution delivery becomes way less med school scientific recommendations and way more practical life. Meet people where they are. And you start to think about the whole delivery system to people, to your comment, John, rather than to kind of solving a health issue per se.
And at the same time, when you talk about it being more human-centric and more about people, you've also made your career with a lot about the application of technology in healthcare. Do those two things go together?
I think absolutely. I think that, this is absolutely true for Homeward. When you look at what resources we have in the care delivery ecosystem, we don't have enough services. We don't have enough resources. And so technology can give you an extension of those services very easily. Technology and data can help you personalize and differentiate what it is that you're delivering. Like almost every other industry, healthcare lags behind for a whole host of reasons and a whole host of different dimensions. But every other industry has benefited from the leverage of data and technology to make things easier, better, faster, and more enjoyable. Right. And the fact that we still wait for 45 minutes for a scheduled doctor's appointment, reading outdated magazines in a waiting room is kind of hilarious. Right. So there's a paradigm shift that we can leverage from other industries and learnings around that.
So what is, one of the things I'm always amazed at, Jenny, is how hard it is for technologists and technology companies to really crack healthcare, or for how the healthcare system to adapt. But maybe since you've sort of been at the intersection of both, tell us what you think technology gets right and wrong about healthcare, and maybe some lessons that you've learned at Castlight or at Livongo that you're applying in building your new company.
Yeah, so as you know, John, I got to learn from you at Castlight, but the Castlight was really technology, absolutely no services. This idea that if we build something and it's useful, people will find their way there and then they will use it. Livongo was maybe a step further in that we leveraged technology and data collection around blood pressure, blood glucose, and then we had a services arm, which was a remote call out from a certified diabetes educator. And I think through both of those, I definitely understand the power of technology and the missing piece of inhuman touch, of human touch in person. There has to be, at healthcare, there has to be a personal touch at some point in almost everybody's journey. However, it's not all the time and it's not never. And so this idea that can we get smarter by leveraging data collection and technology to find the right people at the right time to actually make their experience better, the care better, and the cost efficiency improved in a way that we can actually scale healthcare. I mean, when I look at rural markets, this is our new business, you cannot do a service dominant model in rural. It will not work. It will not work. You also cannot do a pure technology play if you're delivering healthcare. It will not work. And so therefore, you really have to do the hybrid. And by hybrid, I mean a very distinct design around what those needs are for each population. A hybrid kind of technology, virtual and in person, is not a common course. They all have their specificities. And so you really have to look at the exact population that you're designing for and develop a unique hybrid solution.
So I know we've gone from San Francisco to Livongo land to rural. I mean, if you think about these number of things you said wouldn't work in the rural areas, I think there's a lot of things that don't work there. I mean, what is the state of rural healthcare, and is there any hope of making a real difference there? Would you think?
Well, yes, on the hope, or I would not be launching this business. And yes, on the hope, because this is where I'm from. This is my family. I grew up in rural Minnesota. But the state in rural healthcare, this is not a blip. I mean, rural healthcare in America is under incredible crisis. So the mortality rate, if you live in a rural demographic, and that's defined as 2,500 people or less in a metropolitan area, an MSA, is 23% higher. 23% higher than if you live in an urban environment. There is half the amount of access to primary care doctors and 13% the amount of access to specialists. And the problem's not getting better, right? So there's been about 100.
That's getting worse.
Way worse. 167 hospital closures in the last 10 years, 35 of those in between 2019 and 2020. it's massive. It's clamoring for a solution, and it's in many ways been ignored, I think, because it's hard. People said, "Yo, you're doing this new business, like, man, that's going to be hard." And the answer is, yeah, of course, important work is often hard. Hard does not deter us, right? Hard means there's lots of opportunities to kind of navigate within the system.
So on the demand side, that's super clear to me, and all of the breakdowns of the healthcare system that's really is focused on kind of urban and suburban makes a lot of sense. But why do you think you can crack it with what got you excited about your model of kind of tech-enabled primary care risk taking? I mean, all of those things sound like they're urban and suburban products, not necessarily ones that, given the lack of infrastructure, you could pull off in no matter what the demand is in places like rural Minnesota or rural Mississippi. Like what gave you beyond the mission piece? Where's the opportunity?
Yeah, I think as you know, healthcare is there's a lot of timing in healthcare, right? And so there have been a number of organizations who have been successful in taking a differentiated business model and owning total cost of care. And they've done that largely in urban settings, and they've done that largely with services. There's also been a number of companies, and I would put Livongo in this category, that have actually shown that digital care can deliver enhanced clinical outcomes at a lower cost. Livongo's delivery of the technology was not dependent on broadband connectivity. We used cellular connectivity, and that's an enhancement of the infrastructure, the hardware that's at play. And so if you look at these service companies, and they've gotten a lot right, but they were built prior to the evidation or the evidence around these technology-enabled solutions, particularly with cellular enablement, not relying on internet connectivity, because we know that today in rural markets, 50% of people living in rural markets do not have access to broadband still. So there was really kind of a cross function where you could look at the service dominant model, this total cost of care, and apply and leverage the lessons learned within this technology world. And now I think is the right time, because we've seen some workings in both of those different departments to combine them, because they have to be combined to make a difference in rural markets.
So what's the vision of where you take Homeward? And it sounds like they've got I'm glad you have hope for in all sorts of ways, but like what does success look like 1, 3, 5 years down the line?
Yeah, so Homeward, what we're doing at Homeward, to be crystal clear, is we are entering as in-network technology-enabled providers, delivering clinical care for Medicare beneficiaries and partnering with payers to own the responsibility for the cost of care of that delivery. And so in terms of our metrics, John knows me super well. I've got very aggressive metrics. This is a much, much needed solution in these markets. And we're looking at distinct geographies, members on our platform live to spread over time, but really proving out the unit economics in the next 12 months and then starting to grow aggressively from there.
I guess I have a slightly different take, Jenny. When you think about the passive data collection and the continuous monitoring, that what you're saying, the hardware and the hardware infrastructure for cellular, microcellular, and mesh, there's all kinds of ways to get at the data. How do you get people in rural parts of the country to actually use the technology? And what specific things are you thinking about? Are you thinking about Oura rings and whoops? Or are you thinking about, it's obviously not as elaborate as Holter monitors, but what's the hardware you're thinking about, or the monitoring technology? And then how do you get that kind of human machine interaction in a harmonious way?
Yeah, I think that, so I heard a little bit, you bleeped up for a little bit, but what I think you asked is,
Sure.
What kind of technology are we using? And the answer is the technology that people need. And so when you look at chronic conditions, particularly when you look at, so forget about chronic conditions, when you look at healthcare for people greater than 65, 70% of those people have 2 or more chronic conditions, right? And so we'll use the technology that best suits their condition, whether that's a cellular connected scale, blood pressure cuff, blood glucose monitor, heart rate monitor, whatever that is. Data capture through cellular connectivity is seamless. You just kind of use it and we get the data. And then our ability to drive the software and the algorithms to make recommendations is the hard work. And we've done that in the past. That said, I think the probably the most challenging piece of all of this, and the part that excites me the most, is really understanding individual people and what they want and why they have not opted into healthcare in the first place. Access, we know, is an issue, but there's other reasons that people don't seek healthcare. And so our deep understanding, our commitment to be in these communities, generating employment within these communities is a corporate metric, and really embedding ourselves into the existing infrastructure is key to our success. Someone said, are you going to come in and compete with existing providers? And I said, well, that would sure be a dumb business model to go into rural markets as a competitor, where the whole problem is there's not enough providers. And so the answer is absolutely not. You know, we're working with communities, we're working with retailers, we're working with barbershops, we're working with churches. We are absolutely a presence in that community, and we're an extension to give and deliver the services, meeting people where they are, recognizing that it is really untenable to ask almost anyone to go a couple hours one way for a preventive screening visit on a regular basis.
What do you see? I mean, there's other people that have recognized the challenges in rural healthcare, and you have some things like federally qualified health centers that, that are in rural areas, sometimes Indian Health Service, depending on where you are. Are there pockets or examples of things that you say, hey, that works really well, and either you're going to complement it or emulate it, or just avoid those places where it's set up to work?
Yeah, I think it's a combination of, we are absolutely incorporating what works, and but I want to point out that what works as a broad topic is really community based. And so a thing may work in a community, may not work in a different community, right? And so as we enter communities, we're really deeply understanding what it is that's established, what it is that's effective, and how we can integrate that into our existing solution. Again, you have to design with purpose. You know, this idea that, and this is probably one of the biggest lessons that we learned at Livongo, which was at Livongo, like, because you have diabetes does not mean like you are like anybody else who has diabetes, right? It's like you have this one thing in common, but that's about it, right? So similar for rural, not all of our members like own pitchforks and drive trucks, right? They choose to live in these places for a variety of reasons. And so our job is to understand what it is, again, going back to this deep understanding of pain points, right? So we spend a lot of time in the community with our members doing ride-alongs, interviews, to really understand and internalize what it is that we're solving for. If we come in top down, it will never work. Never, never, never. I learned that in medical school, treating people, patients, right? You tell them what to do, that doesn't work. If you start to understand what they care about and then fit what could make it work into their belief system, their goals, it's a totally different outcome and a totally different journey.
How do you contrast what you're doing at Homeward with what you've seen at City Block?
Yeah, it's a great question. And what I would say first and foremost is the team at City Block is wonderful, and I feel very privileged to be on their board. And so that is deep respect for what they're doing. The sheer definition of City Block versus Homeward, kind of urban density versus rural, is fairly different. And so out the gate, we're servicing different populations, different swaths, and in some ways, it's trying to achieve similar goals, which is that both organizations believe that every individual, no matter their economic status or where they live, deserve a right and access to healthcare, adequate, high-quality healthcare. But we're servicing very different markets.
So as you think about Homeward, Jenny, how do you interact then with the primary care docs or the specialists who are already in rural areas?
So at Homeward, we do a couple things. Where our members have existing primary care doctors, we continue to use those primary care doctors as a primary care doctor. Incredible relationship. At Homeward, we're building both primary care services and specialty care services. It's almost without exception, there's very few people who have all their primary care and specialty care services adequately met in the markets where we are. And so where there is a relationship with the primary care doctor, we support around that and provide some of those specialty care services. That said, about 30% of the population does not have a primary care doctor, is not attributed to a primary care doctor. And so there's a great opportunity to come in and provide primary care services as well as specialty care. We call it comprehensive care. So we're not stealing, taking, we are an extension within the ecosystem.
Yeah, that makes a lot of sense. And what we're finding at CareCentrix is that closer to 40+% of people don't have a primary care doctor or don't have any relationship with them. Even if they're attributed, they may not have any kind of relationship. And what's powerful is the comprehensive set of services. How do you develop? So you're basically the open door for the relationships as the community-based organizations. Is that sort of how you're starting to connect with the if you will, the disconnected rural consumer?
Yep, it's a great question. So, when we are in conversations with the payers, right, we'll say, hey, we are willing to come in as an in-network provider and take total capitation for your population. And typically they say, well, great, there's a whole group, to your point, John, there's a whole group of people that are either attributed and have never seen anybody or not attributed. Can you please target those people and try to bring them in with this, your offering? Will that be enticing to them? Can you bring them in and help take care of them? Where somebody is already involved with a primary care doctor, we then partner with that person. But across the ecosystem, right? So again, healthcare is about trust. It's about trust and access, right? And so what is it that's most trusted? And a lot of the community resources are trusted resources because they're local people providing them. And so that is a huge asset to the whole ecosystem to deliver care to somebody, to use, not abuse, use the trust and expand the services that can be given to somebody. So that's where our relationship with the local providers and community assets come into play.
And
it's amazing.
And how much difference do you see? Will it be certain areas that you really focus on? As you said, all the places are different. You can see, for example, one place and it works somewhere differently. Obviously, they're not all the same, but if you don't learn anything from one place, you're just going to keep reinventing what you're doing elsewhere. Will there be some kind of segmentation that you pursue or some kind of a phased rollout as we go to, solving all the problems in the rural America?
Yeah, absolutely. Again, you have to start with one, and then you quickly develop kind of what are the key variants, and you develop 2, then 3, then 4. So we're really good at segmentation throughout the entire journey from acquisition all the way through the care journey and delivery system, as well as our own markets where we're going to enter with different payers. And so, again, the reason in rural markets that I think you have to have both a hybrid and own total cost of care is the healthcare reimbursement system right now does not reimburse adequately for existing providers to do what they need to do with the leverage of technology. And so you have to leverage technology because the density of people is not there. And so there's a lot of dispersion of people. And so the leveraging of technology requires total cost of care. Therefore, the delivery care system requires a hybrid model. Now, I would say that payers are on differentiated parts of that journey in terms of their own eagerness to embrace providers to own total cost of care. And so we've seen that, in the ecosystem. You guys comment this, I'm sure, multiple times, and that's evolving. And so those are the areas where we'll start, where the rails are set up. We're not reinventing reimbursement. We're using existing rails and taking that forward in areas that haven't been addressed for total cost of care before.
So I want to ask you one last question that has, I think, nothing to do with the other ones, but since you seem to be doubly represented, if I understand it, I'm going to go ahead. And that's about SPACs. Is it right that you're on the board of 2 SPACs, and where are SPACs going? And is there more hope for SPACs than there is for rural America, or vice versa?
Well, it is true that I sit on 2 different SPAC-like entities. They're called sales, so they have a different financial structure that bodes better for both the organization and long-term shareholders. So they're set up structurally differently. With that said, it's a similar concept. And do I think that they're going to bode better than rural America or solutions for rural America? I think that there is, I'll comment where I think that that industry is going, but I think there's a huge hope in rural America. I think that's why you're starting to see more entrance and more emphasis in this area. It's so broken, it has to be fixed. And so we will make something better for sure. I also think that when you look at, SPACs or sale organizations or infrastructure, in a market where we've seen 13 IPOs in Q1, I think there was like 110 last year, that the market's changed a lot. And so these are financing rounds and financing mechanisms. And I actually think, ironically, the interest is going to pick up. I think in my journey with this, it's been fascinating to watch people think of an IPO as a destination, like a badge of victory rather than a financing round. And there's lots of ways to get financing rounds and get marketing clout and earn respect within the market that are not traditional kind of IPOs. It's like a very first time entrepreneur wants to push the button, and be on the stage type of thing. So I think that there is a lot of opportunity. I think inversely, it's probably related to the value of the digital health ecosystem, and that there's a lot more work to be done to kind of show true value for some of these organizations. So I think that the SPACs and sales with good line of sight, good thinking, good management are going to do fine and do great, actually. And I think that the organizations and the institutions that are looking for financing rounds will find the right way to do that. But you have to be proven. You have to show your worth in order to get another financing round, right? And so, we're starting to see a little bit of that fallout in relation to the ecosystem.
Great. Well, Dr. Jenny
David,
Schneider,
that imaginary
CEO of Homeward. What, John?
I was going to say your imaginary SPAC is got to be put on ice. Jenny actually represents real companies, so good luck with that, David. The market is dry.
John, I don't know what to say except you're ruining my outro here, but we'll try it again. So I'm going to say thank you to Dr. Jenny Schneider, CEO of Homeward, board member of 2 non-SPAC, SPAC-like entities, and so much more. Thank you so much for joining us today.
Thanks for the chance to chat. Super
so
fun.
That's it for yet another episode of CareTalk. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the CEO of CareCentrix. Thanks, Jenny. And if you like what you heard, or even if you didn't, please subscribe on your favorite service.